and it's MRCPCH Part 1 revision, and it's Neonatology Part 2. First question: 2 hours old newborn admitted to neonatal care unit with RDS. Heart sound heard mainly on the right side and scaphoid abdomen. Oxygen saturation at room air 68%. We requested for chest X-ray. Which of the following is the best way of oxygen administration? Is it by CPAP or headbox, face mask, or nasal cannula, or endotracheal intubation? As we can see here, we have positive data, which is respiratory distress. Heart sound also heard on the right side, so there is something pushed that there is scaphoid abdomen, which is the pseudopneumotic sign of congenital diaphragmatic hernia. So the diagnosis here is congenital diaphragmatic hernia. And to manage congenital diaphragmatic hernia, first step is to tube. So endotracheal intubation and insert NGT. So the correct answer here is endotracheal intubation. Question number 2. Vistian anomaly can be induced by teratogenic effect of which one of the following can lead to Vistian anomaly? And it's quite famous. So is it lithium, valproate, streptomycin, thalidomide, or radioactive iodine? So valproate can lead to spina bifida. Thalidomide can lead to limb deformity. Radioactive iodine can lead to thyroid. And the correct answer appears to be lithium. So lithium Vistian anomalies. So the correct answer here is lithium. So lithium can lead to Vistian anomaly, streptomycin deafness, valproate spina bifida, thalidomide fucomelia or limb deformities, radioactive iodine can lead to fetal hypothyroidism. Question number 3. The most common congenital infection and is a leading cause of sensorineural hearing loss. The most common congenital infection and the leading cause of sensorineural hearing loss. Is it syphilis, HSV, CMV, congenital rubella, or congenital toxoplasmosis? So, the most common congenital infection is CMV infection, cytomegalovirus, and it's actually the most leading cause of sensorineural hearing loss. So, the most common congenital infection and the leading cause of sensorineural hearing loss is cytomegalovirus. Question number 4. The most common characteristic abnormality associated with congenital rubella. Is it growth retardation, early onset jaundice, blueberry muffin rash, radiolucent bone disease, or cataract? And congenital rubella always, once it's come to our mind, should connect it to cataract. So the answer here is cataract. And with congenital rubella, the ophthalmological sign can be cataract, retinopathy, glaucoma, cardiac-wise, PDA, peripheral pulmonary artery stenosis, sensorineural hearing loss, but still the most common cause of sensorineural hearing loss is cytomegalovirus. Also, neurological meningoencephalitis, mental retardation, behavioral disorder later on. Question number 5. All the following are features of congenital cytomegalovirus infection except deafness, microcephaly, chororetinitis, bearing muffin rash, diffuse cortical calcification. It's a quite tricky question. Okay, so with cytomegalovirus virus, there is cortical calcification, but it's periventricular, not diffuse. So I believe it's all are features except diffuse cortical calcification. So the correct answer here is E, diffuse cortical calcification, which comes with congenital toxoplasmosis and hydrocephalus. In cytomegalovirus, we will find periventricular calcification and microcephaly. Question number 6. 3-week-old infant came with poor feeding, micropapular rash, in palms and soles and around the mouth, bloody nasal discharge, on examination hepatosplenomegaly, lymphadenopathy, CBC, hemolytic anemia, and thrombocytopenia. Which infection can lead to that? Is it congenital syphilis, HSV, CMV, or congenital rubella or congenital toxoplasmosis? So, hepatosplenomegaly and lymphadenopathy, bloody nasal discharge, hemolytic anemia, and thrombocytopenia, micropapular rash over the palm and sole and around the mouth. All of this with congenital syphilis. And we have seen cases with congenital syphilis, and it's typical presentation of congenital syphilis. So the answer here is congenital syphilis, and it's hepatosplenomegaly, lymphadenopathy, bleeding, hemolytic anemia, thrombocytopenia. All are feature of congenital syphilis. And if we, in one of you, saw before congenital syphilis, a baby with congenital syphilis, you will find this typical feature. Cytomegalovirus, as we said before, microcephaly, periventricular calcification, congenital rubella with cataract, congenital toxoplasmosis with hydrocephalus, and diffuse cortical calcification. The drug of choice for treatment of congenital syphilis is it penicillin, tetracycline, erythromycin, metronidazole, cephalosporin. And syphilis is the same in adult like neonate. We are treating it with penicillin. So the correct answer here is penicillin. Hypoxic ischemic encephalopathy in the preterm infant is characterized by. The question here is asking about HIV in preterm baby. As we know, in term baby, we can find cerebral edema, cortical necrosis, subarachnoid hemorrhage, involvement of basal ganglia. But in preterm infant, HIE is characterized by BVL. So the correct answer here is BVL. HIE in a preterm infant is characterized by BVL. All other are characterized for a term baby, not for preterm infant. Question number 9. Hemorrhagic disease of the newborn is prevented by administration of single dose of vitamin K 1 mg. Do we give it oral, intravenous, intratracheal, intramuscular, subcutaneous? The correct answer here is intramuscular. So the correct answer here is intramuscular, and anyone who worked in neonatal unit or in labor ward facilitator, he knows that vitamin K just one dose, 1 milligram IM at delivery. Question number 10. The diagnosis of PPHN is confirmed by echocardiography, chest radiograph, electro ECG, cardiac catheterization, pulmonary function test. So PPHN is quite famous in neonate, and actually we diagnose it by echocardiogram. So the correct answer here is echocardiography. And the role of echo is to measure the pulmonary pressure and to see the condition of the shunt. Is it bidirectional shunt? Is it right to left? So it's cyanosis, the baby will presented by cyanosis, and measurement of pulmonary pressure. So the correct answer is A, echocardiography. Question 11. All the following statements regarding EPO incompatibility are true except it became more severe with subsequent pregnancy. It may affect the firstborn infant of A or B blood type. It is less severe than hemolysis in Rh sensitized pregnancy. It is the most common cause of neonatal hyperbilirubinemia requiring phototherapy or therapy. It usually doesn't cause fetal disease other than extremely mild anemia. As we can see here, let us start from E. It usually doesn't cause fetal disease other than extremely mild anemia. It usually, he said, he didn't say always. So it's right. Actually, yeah, this one is right. It's only mild anemia. D, it's the most common cause of neonatal hyperbilirubinemia requiring therapy. Yes, it's the most common cause of neonatal hyperbilirubinemia. C, it is less severe than hemolysis in Rh incompatibility. Yes, it's less severe. Rh incompatibility usually is more severe. It may affect the firstborn infant, A or B blood type. Yes, it may affect the first baby. A, it became more severe with subsequent pregnancies. Actually, there is no relation. So the correct answer here is A. So all are true except A. So the answer of question 11 is A. All of the following are true except A, which is it became more severe with subsequent pregnancy, which is wrong. It's characteristic of Rh incompatibility. This was the last question, and see you in the next video, Neonatology Revision 3.